This is a case of a 37-year-old male, Mr. X, who was rescued from a road traffic accident 1 hour prior. He was found trapped for at least 15 minutes inside his burning car with circumferential full-thickness injury to the right limbs, upper and lower, and anterior trunk sparing his back. Superficial burns also were noted in his face, and he was coughing frequently en route to the hospital, but his O2 saturation ranges from 95 to 96% off supplementation. His heart rate was 110 beats per minute. He was confused and crying out with pain, especially when right extremities are moved. No other injuries was noted. Patient is alone, brought to the ER by paramedics, and wasn't able to answer questions.
Ensuring a patent airway is the first priority in primary survey. Evaluate patency by asking the patient's name as well as the events that happened. Ask the patient to open their mouth and check for foreign bodies, direct injury, or massive edema. Immobilize the cervical spine and stabilize the patient's head by placing a cervical collar and head blocks. Assess the adequacy rate and depth of respiration by auscultating for breath sounds on both lung fields. Administer 100% oxygen with a non-rebreather mask. Check for the oxygen saturation and heart rate. Observe and check the patient's chest movements and respiration. Check the blood pressure. Check the patient's pulse. Check for the patient's capillary refill time. Have an intravenous access for fluid resuscitation. Two large bore peripheral catheters 16 gauge or larger are inserted through unburned skin. Intravenous lines are required when peripheral IV access is difficult. Assess the patient's Glasgow Coma Scale score and check for eye-opening response, motor, or verbal response. Check for pupil diameter and reaction to light. Ensure the patient's privacy prior to removing all their clothing. Examine their injuries from head to foot and also examine the patient's posterior area by performing a Logwall maneuver.
For fluid resuscitation, we use the modified Parkland formula, which is 2 ml times kilogram body weight times percent TBSA burn. So the type of IV fluid is a crystalloid, your plain or Ringer's lactated solution, and the total volume. So using the formula, the answer is 4,500 ml given in 24 hours. So we of course divide it into two, we have the total volume, so that is 2,250 ml given for the first 8 hours, and the remaining 2,250 ml which will be given in the remaining 16 hours. So for the fluid rate, cc per hour, so your 2,250 ml is divided into 8 and then you give 281.25 ml per hour for the first 8 hours, and then the remaining 2,250 ml is divided into 16, so the answer is 140.625 ml per hour, which you give for the next 16 hours.
So for our second survey, we examine the patient from head to toes after the primary survey is completed and the vital sign is stable. So we need to do this anatomical evaluation from the head, chest, abdomen, spine, and pelvis, and the extremity. So we should perform from the history taking, starting with allergies. We need to ask the patient about his allergies or any food allergies, or any allergies from her medication. So the next thing to check is the medication and ask the patient if she is taking medication for the maintenance or the medication. And if the patient has past medical history, such as when was the last patient hospitalized, what was the diagnosis, and if the patient is female. And if the patient is female, we need to ask her if she's pregnant, when was her last pregnancy, or if she ever been pregnant before. And we also need to know the last meal taken and events surrounding the injury. And for this, we need to know the nature of the incident, place of the incident, date of the incident, and time of the incident. But for this case, There was no good response obtained from the ample history that we just performed earlier. So, in stating the complete diagnosis, we need to know the type of burns, the depth of burns, the percentage TBSA, and the areas involved. And for the type of burn is a thermal burn. The next is the depth of burn, which our patient suffers a third-degree burn. The areas involved are the face, the superficial burn with a soot around the nose, the full thickness burn on the right upper and lower limbs, with the circumferential, including the hands, and the full thickness burns on the anterior trunk. All percent is 46%. So, for the management, this patient is visibly in pain, moaning pain. We can use the output for long-acting analgesic. Ketamine, which is also used for intensive burns, dressing changes, and procedure like sclerotomies and anxiolytic like VCDs can also be used. Opioids as tramadol, fentanyl, acetylone, morphine are also used too. For the treatment of long-term anxiety, administration on the anxiolytic such as benzodiazepine, alprazolam, midazolam, diazepam, and diazepam. For the tetanus prophylaxis, we should ask the patients when was his last tetanus shot. Within the last 3 years or more, there is no treatment to be given. With immunization with 10 years, tetanus shot is required. This is a booster. So for our goal here is to minimize hyperglycemia and minimize metabolic feature effect. So this is the best accomplished by early internal nutrition that can be a big hypermetabolic response to burns as gut mucosa integrity, improving intestinal blood flow and motility, and decreasing translocation of intestinal bacteria. Early feeding for burn is more than 20% TBSA, and in micronutrients such as vitamin A, vitamin C, E, and mineral supplementation. Nasogastric tube feeding should be commenced early within the first 6 hours post-burn, as long as the patient is not in hypovolemic shock.
For wound care and dressing, so first we need to remember the TIME concept. T stands for tissue management, I for inflammation and infection control, M for moisture balance, and E for epithelial advancement. So for tissue management, it is important to remove necrotic tissue or exudates or sloughs that are present, since this will delay wound healing. So here we do wound debridement. So first, we irrigate the wound with saline or sterile water. And then remove any viable or non-viable loose tissue. So remove necrotic tissue or any foreign bodies present. Next, for inflammation and infection control. So inflammation, we need to address the buildup of exudates, and for infection control, we need to address the increasing odor and also remove or reduce bacterial load. So here we do moist dressing. So we use your SSD or silver sulfadiazine for partial thickness burns, or your SSD plus your cerium nitrate for wounds with a scar. So we apply the cream directly over the wound. And we apply gauze that is moistened with your sterile water or gauze impregnated with your cream. Here's your wet gauze. So you apply it over the wound. And then we apply a second dressing using your dry gauze. So okay, I already prepared the gauze. This one is dry. So we place it above the wet gauze. And we apply plaster to make it stick. For moisture balance, so this is the rule of your wound dressing. So it is essential to maintain moisture balance to achieve wound healing. Also place or put splints for functionally affected joints to prevent contractures, and for if ever your hand or foot digestions are involved, you can place gauze in between the interdigital spaces. And you can also put a pad behind your posterior auricular area if there is involvement of your ear. Indications for surgery: your limb aspiratum is indicated for circumferential full-thickness burns on extremities and torso, and when the circulation is compromised due to increased pressure in burned limbs, which is not relieved by simple elevation. Fasciotomy is for impending limb compartment syndrome, and when perfusion is still inadequate despite proper sclerotomy. Once stable, you can do early excision and skin grafting of full-thickness and deep partial thickness burns.